As the number of COVID-19 cases continues to mount, doctors and researchers are learning more about the disease every day. Here to explain some of the new findings from the provincial capital, Dr. Allison McGeer, infectious disease physician and senior clinician scientist at Sinai Health System, and Dr. Adrienne Chan, infectious diseases physician at the Sunnybrook Health Sciences Centre and associate professor at the U of T's Faculty of Medicine. And as I welcome both of you to our program tonight, I want to start by reading something that the journalist Ed Yong wrote in the Atlantic magazine just a few days ago to set up our discussion. He wrote, "Scientists know the shape of proteins on the new coronavirus's surface down to the position of individual atoms. But much else about the pandemic is still maddeningly unclear. Why do some people get really sick, but others do not? Are the models too optimistic or too pessimistic? Exactly how transmissible and deadly is the virus? How many people have actually been infected? How long must social restrictions go on for? Why are so many questions still unanswered?" That feels like a good place to start. Dr. McGeer, why don't you start there? Why are there still so many unanswered questions about this virus and disease?
Well, so there's two reasons. The first is it's only been around for 4 months, and no matter how many people you have working on it, there's only so much you can learn in 4 months, and a lot that you learn about infections, you learn because people get infected. So it's really only been a month since a substantial number of people outside China have been infected, and that's just limiting. The second thing, though, is that's really interesting when you watch this is that a lot of the questions are actually questions that remain about other infectious diseases. So we don't know, for instance, why some people get tuberculosis and other people get infected with it but never get sick with it. We don't know why some people carry group A strep in their throat and other people get flesh-eating disease. So there are actually a lot of unanswered questions in general about infectious diseases that have seem like they ought to be obvious, but turn out to be really difficult.
Dr. Chen, is this virus, in fact, and this disease, I guess we should make the distinction. COVID-19 is a disease, but now you're going to help me with the acronym again.
The SARS-CoV-2, yeah.
CO2. Yeah.
SARS-CoV-2.
There we go.
The virus, yeah.
Is the virus. Is it really as inexplicable as Ed Yong suggests in his Atlantic piece?
I actually love that piece. I think Ed Yong has done remarkable coverage in the lay literature around what's going on in coronavirus. I think that the one comment I would have is compared to other outbreaks in the past, I was a resident, actually, one of Allison's residents during SARS. And certainly in my experience with the West Africa Ebola outbreak, the speed and rapidity with which we are learning new information and feeding it back into the care of our patients and in understanding the science and how to manage the outbreak is really remarkable. But it's challenging in that there's clearly a lot of heterogeneity in how things are preventing across the world. And I think there are three factors that play into things that we understand parts of, but not everything. So we know what we're seeing is basically how the virus is interacting with individual humans, like the host. And there are factors that are related directly to the viral pathogenicity, but also individual factors in hosts. And there may be variability in hosts in different areas that may explain why we're seeing what we're seeing. And the third factor is, as humans and hosts, we live within a system or community. And there are system factors that also may impact why we're seeing, for example, the way the disease is presenting in New York or Italy being very different in some ways from what we're seeing in other countries that may be less affected, including in Canada, where certainly we have had a significant burden of disease, but nowhere near as bad as what we're hearing about or hearing reported about from our colleagues in other places that have been extremely hard hit, like New York City, for example. And clearly there are system factors at play there beyond just how the virus is interacting with humans, the human host.
Well, Dr. McGeer, as I hope you remember, because I certainly remember, you and I met during SARS 17 years ago, and I wonder what that experience taught you about dealing with new viruses that you're finding particularly useful as you deal with COVID-19.
The short answer to that is where do you start? Okay, there is no question that the experience of SARS and the subsequent experience of the 2009 pandemic, the Ebola virus outbreak in West Africa, so all of the things that were completely unexpected and in some ways new, have made a huge difference to how we're handling this. You've heard Adrienne talk about how quickly we're able to share data, how fast we're moving forward with clinical trials and with learning things. And all of that is built on this gradual experience. We all walked away from SARS saying, communication was not good enough or fast enough. We weren't able to get patients into clinical trials. We didn't learn nearly as fast as we needed to. And we've taken it from there to the experience in the last Ebola outbreak in the DRC, where in appallingly difficult conditions for everybody, people actually managed to do clinical trials so that we could get real data on treatment and good data on vaccine effectiveness. And all of those learnings are now applied to the pandemic. So it's not, of course, making the pandemic all that much better for people who are living through it at the moment, but it does mean that we are learning things much faster, and even though it's still going to be awful, it would have been much worse had we not put all that learning together.
Just confirming, DRC meaning in the Democratic Republic of the Congo?
That's right. The
Gotcha.
Ebola outbreak that is now almost over in the Democratic Republic of Congo.
Understood. Dr. Chan, let me ask you about how you're treating patients during the course of this COVID-19 pandemic here in the province of Ontario. How are you? Are you hands-on at Sunnybrook? Are you doing telehealth, or what are you doing?
So right now at Sunnybrook, we essentially follow every patient who's diagnosed COVID positive, either in hospital, transferred in, or tested at our assessment center. So it's, I just checked before the interview, and we followed about 274 COVID positive patients right now. And certainly many of them are being followed, obviously, as inpatients or in our intensive care unit. Right now we have about 16 inpatients, 4 of which are in the ICU, and 46 active outpatients. And one interesting thing that I would say compared to my experience in SARS, where it was primarily inpatient care, is with the advent of outpatient virtual care and the investment that the government has put into telemedicine, it's afforded the opportunity to have quite robust follow-up for patients who have mild to moderate illness with COVID, and also has helped to facilitate their care in terms of transition between outpatient management and inpatient management. So the bulk of those 274 patients we've followed only as outpatients, and we've been able to maintain them at home because as a physician, we're able to communicate with them either by phone or through video telemedicine to check in on them. Our hospital foundation funded the support of portable pulse oximetry, which also allows us to importantly check on important vital signs like heart rate and oxygen saturation, partly to provide reassurance for patients who may feel quite symptomatic and also have an overlay of extreme anxiety over those symptoms, so that we know, like, it's okay, we can watch you at home. Symptoms may settle in a few days. Or also it helps us to flag people who may have issues, for example, around low oxygen, and get them into the hospital quickly, but in a controlled way, so that we don't have some of the issues with the super spreader events like we had with SARS in 2003. So it's definitely been interesting to the virtual care piece of providing care for patients that way.
And let me follow up with Dr. McGeer on this angle. You know, I guess it was about a month ago when we got our first modeling numbers, and I wonder whether you people who work in the front lines of the healthcare system are surprised today that the potential inundation of our ICUs and the potential need for, thousands upon thousands of ventilators hasn't really happened yet. You surprised by that?
Well, I have to say I was holding my breath for pretty much the whole 3 weeks while we waited to know how well social distancing measures were going to work, because it was at the time in the middle of March our only option for trying to slow things down and preserve healthcare. But of course, this is a new virus, so the modeling suggested to us that it was going to work, but there was nothing to do except wait and see what would happen. And I don't think there's any question that those physical distancing measures are what are preserving our healthcare system now. And now, of course, it looks kind of easy. It's like, oh, well, the intensive care units are not full. We can start to talk about doing things. But that is really a measure of each and every person in Canada following the rules and staying home and making sure it didn't get transmitted. It's actually a phenomenal social thing that we have, with all of us in it together, actually managed to substantially slow the spread of this virus. Now, of course, that leaves us a bunch of challenges ahead about how we're going to manage it, but it's quite a remarkable achievement that we managed in Canada to move early enough and fast enough so that we haven't had that much spread, and our healthcare systems are still functional.
And to be clear, the fact that we haven't needed all those thousands and thousands of ventilators and ICU beds doesn't mean we still won't if we fail to follow protocols. Is that fair to say?
Yeah, that's exactly fair to say. You know, that the next months are going to be this extraordinarily difficult balancing act between wanting to maintain our healthcare system, wanting to make sure that we don't overload healthcare, that we do have enough hospital beds and ventilators, that we have enough protection for healthcare workers who are taking care of patients, but at the same time minimizing all of the economic damage that's been done. Because of course the trade-off for preserving health is that there have been huge economic losses for a very large number of people. So now we need to try to walk back on the economic damage while still maintaining the healthcare system. And that's going to last months now, I think, and it's not going to be easy.
Dr. Chan, let me get this from you, because we are hearing that some people come in with symptoms of the dry cough and some don't. And some people come in with the symptoms of not being able to smell and others don't. And some people come in filled with symptoms that we've heard a lot about now and others don't. You've mentioned that you've been tracking sort of almost 300 patients at Sunnybrook. What are you finding in terms of who's manifesting the predictable symptoms and who doesn't?
Yeah, so I think, I think there are many people that do follow what to date we kind of feel like is the textbook syndrome. Patients who present with fever, cough, muscle aches, and fatigue have a flu-like illness that settle after 2 to 3 days, and then in around day 7 to 10 start to develop worsening cough, maybe a little bit worsening shortness of breath. In some cases, not such obvious worsening shortness of breath, but clear evidence of lower oxygen, and may then progress to needing ventilatory support in order to tide them through their illness. A small proportion of those patients then may progress to the severe illness that has been well characterized in the literature around hospitalized patients in both China, the US, and Europe, where they get quite bad respiratory distress syndrome and require ventilatory support for a long period of time. But it's interesting, kind of, as you're watching the disease emerge and you're hearing about signal, for example. Sorry.
No. Actually, we want to know what that's about.
So right now, in order to minimize risk, many hospitals have developed intubation teams that you just probably heard overhead that they ask for code airway in the trauma bay. So probably what that means is a trauma patient came in, and because we don't know whether or not the patient has COVID or not, they want to make sure that the most experienced team goes in order to do the intubation in the most protected and controlled way possible to improve the outcomes for patients who are experiencing respiratory distress or who require intubation, but also in a way that it protects all of the healthcare workers, including nurses, respiratory therapists, as well as physicians who are involved in care. So sorry about that distraction.
No, not at all. We like to keep it real here, and that was very real. Dr. McGeer, tell us this. I have seen lots of reports that by the time a patient has to go on a ventilator, how do I put this? Well, like it's curtains, like it's almost too late. Like a ventilator will help them have a more, an easier death, but there aren't that many people who, once they're on the ventilator, come out of it and then get to leave the hospital. Yes, there have been some very high profile and dramatic examples of that happening, but in the main, it's really not good news. Can you just clarify all that for us?
Well, when you're sick enough to need a ventilator to help you get oxygen into your bloodstream, yes, that is a very dangerous situation. It carries, no matter what the cause of it is, COVID or not, it carries a reasonably high risk that you will not recover. But in fact, there are lots of patients with COVID-19 who've been in the ICU and recovered. I think some of the stories that I've read from those people tend to be young, healthy people who were interviewed, a week or two after they got out of the ICU or out of the hospital, and are still feeling really awful and are saying, this is going to be terrible. But in fact, people recover from that experience. It just takes time. It's like running ultra marathons. Having an illness that severe, it takes a huge amount of your body energy. And if you're young and well, you recover usually almost completely afterwards. So yes, being on a ventilator carries risk, but there are many patients with COVID who have been on ventilators and who have survived and will do well.
Good to know. Dr. Chan, I've heard of this thing called Covetotoes, but I'm not exactly sure what it is. Is this a real thing? And if it is, what is it?
Before I get to Covetotoes, I just wanted to reiterate Allison's point on that, because I think a lot of the early literature that came out, in particular in Italy and New York, where the system was overwhelmed, the outcomes of critically ill patients there, I would say in my clinical experience here at Sunnybrook, they seem a lot worse in those descriptions in this situations where the system is overwhelmed. And certainly at Sunnybrook, we've had a lot of patients who've been intubated that recover. Obviously, if you have, like Allison said, a better underlying, I guess, habitus in terms of comorbidities, you're more likely to do better. But we've also had some patients who've had multiple comorbidities survive and get extubated and are now out in rehab or even at home. So I think that's an important piece. And perhaps it's because our system wasn't overwhelmed. Now, the Covetotoes thing has kind of, every once in a while, you kind of start hearing on social media, and the media picks up on these things. And Covetotoes seems to be the thing of the week. Even my mother was asking me about it, which is how I know it's kind of out there. And that's just related to reports from both pediatricians and dermatologists that they seem to be noticing patients that seem to have what looks like the kind of toes that you get after you've gone through frostbite. So it's thought to be related to little microclots that might happen in the blood vessels that feed the skin in that area. And I think people are wondering whether it might be related to some of the hypercoagulability that we're hearing about and seeing in COVID that might be associated with it in terms of increased risk for these small clots or even larger clots to happen. So whether or not this is something that just happens in a minor subset of patients, I think right now it's hard to say. We're definitely hearing reports. I can tell you in our Sunnybrook cohort, I have not had any patient with Covetotoes yet, but it's certainly something interesting to keep an eye on, and certainly something that I suspect might pop up in particular for the dermatologists and the pediatricians to keep an eye on based on what's been coming out.
Gotcha. Let's go back to that Ed Yong article in The Atlantic that we referenced off the top of our conversation, and I'll read one more short excerpt from it. SARS-CoV-2 is the virus. COVID-19 is the disease that it causes. The two aren't the same. The disease arises from a combination of the virus and the person it infects and the society that person belongs to. Dr. McGeer, let's understand that. The society that person belongs to. What does that mean exactly?
Well, I think what he's talking about there is the interaction between virus and disease depends on who you are, depends on what your underlying illnesses are. It may well depend on how you get infected. There are some diseases where if you get infected from very close contact and get an exposure to a lot of virus, you're more likely to get more ill than if you get exposed to a small amount of virus. It's also true, as Adrienne pointed out, that from Italy and Iran and New York City, we've seen what we believe to be true, but fortunately have not experienced before, which is that when the system becomes overwhelmed, when you're managing, as one of the recent New Yorker articles described, 23 intubated patients in your emergency department using ventilators that are, old and not hooked up to the proper oxygen, people just don't get as good care. So how well you will do if you get a COVID infection is an entire mix of perhaps how you got exposed to the virus in the first place, what your health is like as underlying health, which is different from country to country, how old you are, right? Countries with people of substantially older age, like Italy, are going to do worse in terms of the number of deaths than countries that have younger populations. And then it's how well we preserve healthcare is obviously also critically important to what happens to people when they get sick.
And Dr. Chan, let's do a little comparing and contrasting. The way the province of Ontario is experiencing COVID-19, how different is it from other jurisdictions in North America that we would want to be compared to?
I mean, one thing, and I think this goes back to what Allison was talking about, and I think what Ed Yong was also referring to this article is, again, thinking about what's happening in New York. Not only is where the capacity is overwhelmed, but you're also seeing in the U.S. there's clearly a disproportionate number of African Americans who are affected and are actually dying from the disease, and you really get to thinking. We don't have that data here in Ontario, but based on my anecdotal experience, there are clearly issues around socioeconomic status that impact how the disease presents. And I think in the US, perhaps it may be related to issues around access to healthcare and also systematic issues that may be contributing to some of these poor outcomes. And I think that's an important piece to highlight. Here in our jurisdiction, we're seeing particularly people who are, more recently, I would say in the last few weeks, I think we've done a great job in terms of managing the impact on acute care facilities. But I think collectively, we've clearly failed in terms of our response towards people who live in congregate living facilities. I think there's been
care homes and the like.
Thinking about that, and also facilities like shelters for underhoused, where there've clearly been outbreaks. I think that some organizations have done a great job in trying to mitigate some of that. At least in Toronto, the Inner City Health Associates has done really good work with partners to set up other facilities that persons under investigation and COVID positive patients can go to and isolate. And we're not seeing as severe outcomes as we're seeing, for example, in the long-term care homes, where essentially we have like two outbreaks right now. The community outbreak that we've all collectively seem to have started to flatten the curve for. And then these long-term care facilities, which are essentially driving our case counts and our mortality counts as people who live in those facilities, and also the staff that are working in those facilities are getting affected. So I think those
Dr.
would be
McGeer?
some ideas in my head.
Understood. Dr. McGeer, in our last minute here, I just wonder if you could weigh in on one of the biggest issues that I think people want clarity on, which you may not have clarity on yet. But the notion that once you get this thing and you get through it, you've somehow got immunity for life. Do we know that yet?
No, we don't. And I think the very beginning of evidence is evolving suggests that that is probably not true, at least not for everybody. And it's probably not true for two reasons. The first is we're learning that people make different levels of antibody, and people who have less severe illness may make less antibody. And that may, in fact, mean that if you have less severe illness, that you're at risk of getting it again, even if the virus doesn't change. But we also know that the virus has changed, and being a coronavirus, it's reasonable to expect that it might keep changing. So I think you can continue to hope that if you've been infected, that you are protected for life. But the probability is that that's not true. The good news is the second infection, if you get it, is likely to be less severe. And that's not known absolutely for this virus, but it tends to be true about infectious disease in general. So it's more probable than you will be protected for life.
Well, we'll take that little bit of good news and run with that. Dr. Allison McGeer from the Sinai Health System, Dr. Adrienne Chan from the Sunnybrook Health Sciences Centre. Really good of both of you to join us on TVO tonight. Thanks so much.
Pleasure
Thanks,
to talk
Steve.
to you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.